discussion with all of you. So as I said earlier, we had that wonderful opportunity given to our attendees to actually submit some of the questions that they have. And one of the reasons why we were doing this is because we have some families who have been in the community for a very long time. And then we also have some families who are just joining us in their new journey in the inhibitor community. So we wanted to give people the opportunity to really have the questions answered that are burning their minds. So with this, Chris, I wanted to start talking to you a little bit more about some of the questions that have been submitted here. And one of the first questions that was provided is really, if you could elaborate on this a little bit more, what is actually the physiology behind an inhibitor, and how do we actually diagnose this? What is this inhibitor?
That's a great place to start. So I think to sort of simplify it a little bit, think of an inhibitor like an allergy. Our immune system is set up to recognize what belongs to self and what shouldn't be there. So in this era of a pandemic, we talk a lot about viruses and how our body fights viruses. Well, if you're not making your own factor 8 or your own factor 9, and we expose you to those proteins, especially when you're a baby and your immune system's just trying to figure things out, there's a possibility that your immune system will treat it like it doesn't belong there and try to get rid of it. And that's sort of what an inhibitor is. It's an antibody to a protein that the body doesn't recognize. Even though we know it belongs there, the body doesn't, because it, in many cases, hasn't made its own. And so it seems like a foreign protein. And then the way that we diagnose it can be a couple of ways. So one, we know that these inhibitors happen early on. So we're actually looking for them. So every 3 to 5 exposures to factor, we want to check and look for an inhibitor, and we're actually measuring for that antibody. We also, sometimes inhibitors can sneak up on us. So it might be somebody who started on prophylaxis or regular infusions to prevent bleeding, and all of a sudden they're having bleeding, and we don't expect that. So that's a big red flag. Or we're treating a bleed and it's not getting better. And that again is a red flag, because if we're treating with factor and that doesn't seem to be stopping a bleed, that's another time we would look for an inhibitor. And then sort of the last case scenario is somebody who has maybe mild hemophilia, who hasn't had a lot of exposures, but has a mutation that increases their risk. And those sometimes will pick up either after a surgery or in our annual screening. And that's one of the reasons that even if we expect most inhibitors will present early on, some present much later. And so it's really important that we screen at least once a year for an inhibitor. So hopefully that answers the question.
Yeah, so are there actually some specific risk factors that have been identified?
Yeah, so the biggest one we know about are certain mutations. So we know that there are certain mutations, usually bigger mutations, that put you at risk, because then you're less likely to be making any protein at all. But we know from some of the sibling studies that even if you have a high-risk mutation, not everybody develops an inhibitor. So there have been some cohort studies that looked at other risk factors. And one of the first things that popped up was age. I kind of mentioned that we tend to see them in our younger patients. But what was really interesting was when they looked at age, it wasn't just the age that the child was exposed, but it had a lot to do with why. Why were they bleeding? So circumcision bleeding is less risky than having an intracranial hemorrhage at birth. And that has to do with that sort of inflammatory response, which revs up your immune system and maybe makes it more likely that you'll develop those antibodies. And also the dose and duration. So if patients had been exposed to factor for more than 5 days or at higher doses. So we talk about those as sort of danger signals. So it's mutation and danger signals sort of combined. And then the other thing that we don't have a lot of explanation for is race. So we tend to see inhibitors more in patients of color, African American, Hispanic, and that's across mutations, and we don't fully understand why that's the case, because we know hemophilia affects all racial and ethnic groups, but we tend to see inhibitors more in those patient populations.
Absolutely. Do you know of any studies that are currently still going on or so to really pinpoint these elements a little bit more down?
Not currently ongoing, specifically looking only at inhibitors, but I will say, that some of the audience may have heard of the SIPPET trial, which was one of the most recent sort of gold standard studies, which is tough to do in hemophilia, where you have a randomized controlled study. So this was an international study where they had patients getting either a recombinant product or a plasma-derived product, and they followed them for inhibitors, and they looked at mutations, and the groups were pretty similar. And that study actually statistically significant difference with patients on plasma-derived products getting less inhibitors, not zero inhibitors, but less. And so that was helpful information. Because the other studies that I mentioned earlier were all retrospective, which, it's sort of difficult to really sort of extrapolate how well that is going to pan out. There are other studies, as drugs come to market, they're always looking at inhibitor development. So the first studies that any drug company does is what's called a previously treated patient trial, because they expect about 25% of factor VIII patients will develop an inhibitor, and about 5% with factor IX. If a new therapy coming to market had a higher inhibitor rate or had inhibitors in previously treated patients, that would be a big red flag. So it wouldn't proceed. And I will say that all of the clinical trials looking at new products now are also looking at those genetic mutations to get information about who's developing inhibitors on their products in the previously untreated patient trials, where we do expect a certain percentage of patients to develop inhibitors.
That's very interesting. Great information here. Now, with all of this, have you seen or noticed any differences actually between hemophilia A and hemophilia B?
Yeah, huge differences. So I already mentioned that there's a difference in the percentage of patients. So much more common, over 25% of patients with hemophilia A develop these inhibitors. Far less common in hemophilia B, less than 5%. But clinically, as a nurse in the center, it's a big deal when some of our hemophilia B patients develop inhibitors, because they can actually have an anaphylactic reaction or anaphylactoid reaction to the factor. And that might be the first time we know that they have an inhibitor. So at our center, when we have a baby with severe hemophilia B and we're worried about an inhibitor, either because they have a null mutation or because we don't know and we need to be cautious, they get their first 10 to 20 infusions at the center. And we leave an IV in, they stick around for an hour afterwards just to make sure that they don't have that reaction. Mm-hmm. And they're also a little harder. We don't have as much data on our hemophilia B patients. It's a smaller population. Some of our bypassing agents have factor IX in them, so we're limited, especially for those patients who have allergic reactions. So for those patients, sometimes we can't even talk about tolerization until we talk about desensitization. So they might need to get sort of used to seeing factor IX without having an allergic reaction, and then we can talk about tolerizing them. So it's much more difficult.
Mm-hmm. Yeah, that's interesting. Now you're bringing up this point on treatment there a little bit and tolerization. So this was a question that was actually given in our previous session, is really, what does this word mean, to tolerize? What is that? And then along that, how do we actually treat an inhibitor? What do we do about it?
Okay, so two really good questions. So tolerization is actually sort of, I'm going to go with the definition that we use in our clinical trials. And so it's a 3-step process to really tolerize someone. So when someone has an inhibitor, obviously we want to get rid of the inhibitor. And so along the way, we've got to sort of check the boxes. The first box that we want to check is that we get rid of the inhibitor. So we can't measure it. Okay. And that can take a while, and most of our immune tolerance regimens involve giving factor at regular intervals, sometimes at higher doses, to get rid of the inhibitor, and that can take months. But that's not enough. So the next step is to make sure that the factor stays in the system for longer to achieve what's closer to a normal half-life. So if the half-life of factor is 8 hours, getting to at least 60% of that. And then the third step is, and then the third step is having the factor stay for days. So let me say that again. We want to get to 60% of our recovery first, so that you can actually get, if you're aiming for 100%, you can get to 60%. That's step 2. The third step is having the half-life be at least 66%. So in the clinical trials, a successfully tolerized patient had no measurable inhibitor, had a 2/3 of the normal recovery and half-life. And again, that can take months or years.
Yeah. So is it ever too late to start that whole tolerization process? Is there like a cutoff?
No. No, I mean, I think we have learned that, and the guidelines suggest that it's not too late to try, that there really is a benefit if we can tolerize patients to quality of life, being able to prevent and treat bleeds better. And so we have lots of different mechanisms to try to get rid of inhibitors. And so we don't want to say that we shouldn't try.
Mm-hmm. And then another question that came in too was, once somebody has been tolerized, can the inhibitor become active again?
Yeah, it can. And what we don't know is, when we don't know if there's a time where we don't need to worry, and it may be patient dependent. But I think we all want to be very cautious with our tolerized patients. And so typically, in the era of factor prophylaxis, we were just continuing on prophylactic regimens and constantly exposing our patients to factor and keeping that potential reaction at bay. One of the challenges for us with the new era of non-factor prophylaxis is what might happen to those previously tolerized patients if they stop factor prophylaxis because they're on emicizumab and then they get exposed to factor again. And we don't have the answer to that. So that's the patient population that we watch very closely on emicizumab and screen for those inhibitors going forward.
Yeah, that's great. So I do want to ask a couple of questions to Jen here as well that really came in from our audience. Thank you so much, Chris. So Jen, one of the questions that some people have had is there actually a difference in joint health between people with hemophilia and those who have hemophilia with an active or a tolerized inhibitor? Have you in your clinic seen any differences in regards to joint health there?
Thanks, Lena. I think that's a really interesting question. You know, and I think I'll kind of go around about in answering it. You know, we're born, thankfully, hopefully all of us with the same trajectory as far as joint health goes. And then with or without, and hopefully we're not born with an inhibitor, that I'm not familiar with. So we develop over time. I think as a physical therapist, one of my primary roles in the clinic is to be a monitor and an educator for joint health. And so my clinical exams are extremely critical for patients in their early developmental years, as well as with activity. And so when and if an inhibitor is identified, I think it depends on how that happens, whether it's after a bleed and a lot of factor, like Chris mentioned, whether it's spontaneous and we're not sure how. From my perspective, from a PT perspective, I'm monitoring their joint health. And so depending on how quickly that tolerization can happen, that's when I see a difference in joint health. So some people with an inhibitor who get one from a young age may start and end up with one bad joint. And my hope is in today's world with the therapies that we have and with, especially in hemophilia A, with good compliance to the therapies that we have, that perhaps we can prevent even any further joint damage from occurring in any other joints if they were affected. I think the key is consistency. The key is prevention and education and monitoring of joint health. Like I said, I'm very critical, especially for our patients who have a tolerized inhibitor, very, very critical in their joint exams and monitoring what their range of motion is. I know those joint range of motion measurements annually can seem a little cumbersome, and why are we doing these again? But those little 2 and 3 degree discrepancies that happen, especially maybe when we're a little bit older in our 20s and 30s, they add up and can really impact someone's function. So I think the bottom line is, are our joints different? Not initially. However, it just depends on how that inhibitor has affected you, how lucky, or just how it all works out with the meds and tolerization, and then also with between hemophilia B and hemophilia A with inhibitors. I think there is a big difference in joint health for sure, especially as people age. Hopefully the new medications will start to come on board similar to with hemophilia A, and that will be very helpful. But I think prevention is key, especially for hemophilia A and B with inhibitors. And there's a lot of intervention that can happen to help prevent any further joint damage and maximize quality of life that your physical therapist and your HTC can help you maximize your world with.
Absolutely. So you touched on this a little bit, but you have said too, like a lot of the products have improved over the last couple of years. And some of the questions that came in were really with these improved treatments that we have right now. A lot of people are getting more active. They're able to do more things. What are some of the top advices that you give to people to really make sure that they are not damaging the musculoskeletal system and overdoing it?
Yeah, it's a challenge because there's an opportunity here now to go on an adventure that perhaps someone was fearful of before, which I think is a fabulous place to be, because we've got opportunities for strengthening, for enjoying things that perhaps you were too nervous for a good reason to do before. And now with these new therapies, there are opportunities, but then there are also risks. So just like anybody else who may not have a bleeding disorder, there's that weekend warrior syndrome where somebody who just says, I'm going to go play a game of soccer, and they haven't played soccer. They're 35 and they haven't played soccer since they were 15. More than likely that next day they're either going to have hurt themselves or they're going to really suffer for a few days with muscle soreness and pain. So I think the key is starting off slow, and that's the bottom line. I think your physical therapist can really help you to figure out where your current level of physical function is and where you can very slowly and methodically increase. I tell people we want to start off painfully slow to make sure that what we're doing is not causing any harm. And then from there we can increase, but this may take 3 to 6 months for you to feel like you're actually increasing in your strength and your stability, because it takes honestly 6 to 8 weeks for your muscles to actually build strength. In between there, you are just making things more of an efficient and functioning group of muscle cells working. So you have to be patient. And I think that's one of our biggest challenges as human beings, is being patient. But that is really the only thing and the primary thing that's going to prevent someone from being injured. And I think doing things consistently. If you want to gain strength, you're going to have to commit to a program where you're doing it actually 4 or 5 times a week in order to gain strength. Once you gain to that strength, then you can back off to the 2-3 times a week. Some people say once a week to maintain strength. I would recommend for good habits use more than that. But the bottom line is you have to go slow, listen to yourself. And then I'm going to share my screen real quick here. There's something called the RPE scale. And hopefully everybody can see this. A way for you to just pay attention to how much effort you're putting out. So something like watching TV is a 1, or something that you are completely down and out about, that's a 10. These extremes are obviously not things that we necessarily want to do that are healthy to build strength and good physical function. We want to really focus in this green area if possible. If you're just starting to do any kind of activity, let's say that you had a bleed, if you did anything before, perhaps a 2 or 3 is really where you need to begin. And that is okay. And I think that it'd be a fantastic thing for you to say to yourself, I can do this. I'm breathing easy. I didn't have any increased pain. Soreness is a new thing that we all have to learn about. That isn't necessarily a bleed. And that's a whole nother topic that could probably be an hour-long presentation. But I would really encourage people to kind of think about this scale as a way of grading how much activity you're doing. And so I think thinking about that is a good way to monitor yourself and not overdo. But starting slow, and slowly progressing. So the last thing I'll say about that is you wanted to do a walking program, for example, and you've never really done an exercise program. I truly start people out with 5 minutes. Let's do 5 minutes of walking for a week, 5 minutes in a row without stopping. And then next week, do 6 minutes. After that, you do 7 minutes. And that's what I mean by slow. I think we all get excited and think we can triple and double things, but that is really the way to win, and also where we find our thresholds, and being respectful of ourselves, because our threshold is going to be different from somebody else for all kinds of different reasons.
Yeah, thank you. Thank you so much. So I want to ask a couple of questions, and also to Sabrina here. In the interest of time, I would love to keep talking about this topic, obviously, but thank you so much, Jen. So Sabrina, there was a couple of questions that came in that were really focused around identity. And one of the questions was like, how do these better treatment options that are now available really impact the patient's sense of identity? So the patient who does have an inhibitor.
Thanks, Lena. So I definitely think that with the better treatment options, they impact an inhibitor patient's sense of identity and their quality of life, and giving them the option, the opportunity to really enjoy the different type of activities that bring joy and happiness to their life. Without these different types of better treatment options, then people are more limited, and we hear about that in clinic. But I believe that self-esteem grows, self-confidence, and also feelings of empowerment, this freedom of opportunity to really delve into what you enjoy. And also, as Jennifer mentioned, be cautious, as you're going and enjoying all these activities, not to delve in too deep as the weekend warrior, but have a balance, like she mentioned on the scale that she shared with us. I've heard about many patients who they look sort of as their backup plan. These are the things that they've learned about, that they've discovered about themselves, different talents, different capabilities. It may not be so physical, but then you have a blend of both being able to enjoy your physical activities and other type of hobbies and interests that are appealing to you.
No, great. So a couple of other questions came also in and kind of along this too, like how in this whole process, how important is a support network, and how do you go best about really establishing a good support network?
Right, and this is something that's very important to social workers. Our background and our training is in a person's support system. That's why it's so important. Every time you come to clinic, we sort of do like an inventory of who your support system is. And in some cases, we see how we can expand and grow your support system. We talk about different opportunities within the bleeding disorders community to get involved or to attend educational events and so on. But very much. And I think it's important to, even at a very young age, teach children and teenagers and also young adults how important it is to have friends not only in their community at large where they live, but also within the bleeding disorders community. It's so important to have other people who can really relate to what you're going through, and that you feel like you're not alone in this. There's other people who really understand, and they're there for you. So the bleeding disorders community does an excellent job in having those opportunities available for both male and female patients.
Absolutely. And now, if I'm not so much a friend, if I'm actually in that position of being in somebody's support network, let it be that I'm a sibling, I'm a parent, I'm a friend, I'm a partner, how can I, in that role, really support the person who has hemophilia and is living with this inhibitor effect?
Yes, so I think it's a combination of not only the HTCs, but the HTCs partnering with the chapters, and then also on a national level. It's the whole community coming together and seeing how we can help the person and the family unit at large. So it may be consultation with the social worker and the chapter members, who would be someone that the parents can turn to, other parents, or mother to mother, or father to father. That way, they can discuss what they're going through, but also find reassurance that everything's going to be okay, and you have a big, huge community behind you that's here to support you. And then you also mentioned the siblings. So opportunities as well at chapter events for the siblings to come together, for the sibling to be recognized and acknowledged if they come with their brother or sister to clinic, and our staff, the HTC staff, making time for those siblings and really, praising them and encouraging them for being so supportive.
Yeah, so you are mentioning the term chapter there, and we do have a question that I think fits in here quite well in this very moment. So what is this chapter? What does this word mean, and what do chapters do?
Sure. So we have our 2 large national organizations, and then in every state or surrounding area, you would have chapters where you have, for example, an executive director, you have a board that comes together, and they are a huge part of the support systems. I can tell you that, for example, some of the programs that they offer for patients and families are Helping Hands. They have that on a state or a chapter level, where if you work with your HTC social worker, they can make a referral for you to your local chapter, and they can help you with financial needs pertaining to your bleeding disorder. Or perhaps you'd like to sign up to receive emails from your chapter as to when they're having events, family day, all kind of different opportunities for you to come together with the community at large. And it just continues to grow and go on as to, the different ways the chapter is there for our patients and families. And I think very much that the HTC is a partner in working with the chapters to make sure new families, for example, know about how to receive a packet of information and be connected with those family members, or to have the support of the chapter behind you and each family member as well.
Thank you. And then, yes, so the large national organizations work very, very closely with the chapters as well, just to put a little plug in there. So another question that came in is, if we are a family with a child who has hemophilia with an inhibitor, that focus is often shifted to that child. So as parents and caregivers, how could we really make sure that we are kind of fairly dividing the tasks, and how can we make sure that our relationship really stays intact as well?
Well, for parents and caregivers, as they're caring for one child who has a bleeding disorder, going back to the sibling, asking and giving the sibling the opportunity to express themselves, how much would they like to be involved? Would they like to come to the clinic visit? If the child with the bleeding disorder with an inhibitor has to go into the hospital, at what times would they like to visit, spend time, but then also respecting and recognizing everything the sibling enjoys doing and having carved out special time for them and their activities. And that may be, for example, parents splitting time and making sure that they are able to divide up and perhaps go and visit their own child with the bleeding disorder inhibitor in the hospital, and also another parent or primary caregiver spending time with the sibling or siblings.
Mm-hmm. This is something that people could also come to their center social worker and talk to. Is this a topic that parents can raise with the social worker?
Yes, absolutely. And we have educational programs within the bleeding disorders community. So, for example, formerly it was referred to as Parents Empowering Parents, but we have an educational program where it's now empowering, energizing and empowering parents, EEM. And what that model does, it's a teaching model where it's not only parents within the community, but it's also HTC members, it can be chapter members, and we come together to help parents in raising their children and their siblings. They learn all kinds of skills as to, for example, appropriate parental discipline, how to hold family meetings. Again, you're helping the children to develop skills, and also for your child with a bleeding disorder with an inhibitor to learn how to manage their own chronic condition.
Absolutely. Another question that came up in the chat here that I wanted to address with you very quickly. So we often hear about all the measurements that we do about the physical health, about joint range of motion, our strength, and so forth. But do social workers do specific, maybe standardized measurements of our psychosocial well-being as well in the clinic?
Yes, I'm glad you asked that question. So we actually have a patient health questionnaire which has a number 9 after it, and it's referred to as the PHQ-9, and it is a very reputable tool that's used in psychiatry. For patients, when they come into clinic, you know, we screen for depressive symptoms. We always talk about it, and we start at a very young age to get the children familiar with it, to raise awareness with the parents as to how important it is when you're managing a chronic condition, to also take good care of our emotional and behavioral health as well. So children these days and teenagers are learning so much in the school system. So that I've seen how it's become more a topic of normalcy, whereas before they were learning about it, but now fortunately the schools are also taking on that teaching approach. But we do talk about depressive symptoms. We talk if anyone is feeling suicidal. We talk about depressive history in the person. We talk about family history of depression. We also talk about, are they receiving any counseling or therapy? But the most important thing, if say, for example, someone is non-insured, we want to make sure to break down those barriers. And either the HTC may offer, for example, free counseling sessions that's provided by the treatment center, or, you know, in providing patient options, making sure that they know of community resources within the community that they live in, and ensuring that no one goes without. So that PHQ-9, it tells us right away, it's like about 9 specific questions as to how you're doing. It's like a snapshot. And, you know, how are you getting along with your relationship with other people? Then we're able to look at that score and base it on a scale. And along with that gives the patient an idea how they're doing, a visual tool. And we keep repeating it whenever the patient comes to clinic as well, like a check-in, an opportunity to really just raise that awareness. And maybe someone is struggling with their decision as to whether or not they want to reach out for counseling sessions. So in doing that PHQ-9 and talking about this every time we come to clinic, it helps plant a seed and really help empower the patient as to what choice they would like.
Great. Thank you so much, Sabrina. So I want to make sure I'm addressing all the questions that are coming in the chat as well. So I'm going to ping this back to Jen very quick, because this is a particular question more for her. And the question that was coming in from a chat, if there is somebody who has hemophilia and who has developed an inhibitor more as an adult, and now they've really lost their ability to walk, like how can they actually strengthen their muscles again to really be able to walk again and maneuver again? What are some of the best techniques or tactics here?
I think that's a great question. And I think depending on where you live and depending on the resources that you have at your disposal, the most ideal way of starting, I think, would be in the pool, doing some slow, progressive strengthening with a physical therapist, if possible, in the pool. And if it's not your HTC physical therapist, hopefully your HTC physical therapist can help you to coordinate with a local physical therapist. And that HTC, one of the roles of the HTC PT is to discuss with that local therapist about what an inhibitor is, about your personal needs, and to give you some guidance on, and give them some guidance on how best to progress you really slowly and carefully. But starting in the pool would be a fabulous option, because you can do things. We talk about eliminating gravity. Well, we can use buoyancy, if we go back to high school science, and we can eliminate buoyancy to even make things a little bit easier. We also can use buoyancy as a resistance and use all kinds of other fun things in the water. If the pool is not accessible, there's a type of exercise that I still would recommend you start with a physical therapist. It's called isometric exercise, which is just plain strengthening and tightening up a muscle, almost like when you make a fist, you can feel your biceps muscle kick in. That's an example of an isometric contraction. And you can do that very systematically at different angles to target different things, to get different muscles to kick in, but it's actually one of the least stress to your joints, but also one of them, a great exercise. And if you do it enough, it can actually be really, really, really helpful, despite being really, really boring. It is actually really effective and recommended. So that's kind of the starting point, and it's only uphill from there. If things are getting harder and harder in your PT sessions, that means you're doing something right.
That is very true.
Mm-hmm.
So I wanted to ask a couple more, just a few more questions, and those are really to all three of you. So obviously we are going through a pandemic still. This pandemic has impacted all of us, no matter where we live, no matter where we are. So, and one of the big concerns that people are really talking a lot about and that are surfacing are a lot of the health inequities that are there. So, there were a couple of people who really wanted to know, what are some of your biggest health equity concerns right now? If you could name two of the biggest issues that you are seeing. And then also, did more of that actually surface during this COVID-19 pandemic?
Yeah, I can start, and I'm sure we all have sort of similar but different experiences. Obviously, in the era of needing to keep social distancing, the hospital had to pivot very quickly to continue to see patients, and so we used a lot of telemedicine, which has been phenomenal, and we've gotten very good at it. But what it highlighted was the fact that many of our patients don't have access to Wi-Fi, and in particular, some of our patients who are where English is not their first language, the issue with interpretation became more of an issue. Not so much on the call, because we could get interpreters to be a part of the call, but actually getting everything translated that has to go out to the patient in advance of a telemedicine visit so that they could log on. And, you know, that's something that we want to continue to use going forward. And so we need to really work on addressing those barriers to telemedicine, because I think it's going to be a great thing. And, you know, we need to continue because it addresses some of the other access barriers like transportation and time off work, but definitely highlighted some of the inequities that we need to address.
Absolutely. Sabrina, Jen, anything that you guys wanted to add here?
So during COVID-19, what I have seen as far as challenges for our community is I've seen more situations where people have lost their jobs and they're having difficulty paying their rent. So, you know, I'm drawing on our resources within the bleeding disorders community. Our chapter has COVID-19 resources for which we are so grateful, and they have helped so many patients be able to pay their rent while they're without employment right now. And then, of course, on a national level, we've been able to utilize COVID-19 resources very similarly. And then we also have the National Organization for Rare Diseases that I want to mention and make sure everyone knows about. They also have a waiting list that they will help patients with their rent or their living situations. So as an HTC social worker, the priority I have seen are finances. One of the things that I would recommend you all check with your HTC social worker about is see if your clinic can provide you options for transportation. We do provide round trip transportation through a local cab service for the person. Our chapter, with prior arrangement, we can arrange a hotel stay because Texas is such a huge state. So you have people driving, you know, that they would have to get up at 3 or 4 in the morning or maybe earlier so they could make an 8 o'clock a.m. appointment for their adult clinic. So the chapter helps out with hotel arrangements for those patients. Utilize your chapter and your HTC staff to help you with some of the barriers or situations to get to clinic.
Fantastic. Jen, any
Yeah, I think the two big ones that I have noticed in North Carolina, at least, one is primary care access. There's, especially in rural areas, there have been a lot of primary care practices that for whatever reason have closed. And so a lot of our patients are having to find new PCPs in areas where those were slim to begin with. So I think that has become a really challenging thing. And then the other and more personal and dear to my heart is nutrition. I think there were a lot of children who rely, as we all know, on school lunches, and with schools not being open, a lot of school systems have done a really good job at trying to create food drives as well as stops for people to come in, no matter whether they attend public school or not, to get lunches and hot meals. But regardless, that requires transportation, effort, access, gas, and all of those details. And for along the same line, so that's with lack of access to food. We've also seen a lot of people gaining weight, which with joint health as well as general health and wellness, that is a problem, especially when you're receiving a medicine that is also weight-based. That also can decrease the effectiveness of the current dose that you're taking if you have gained a significant amount of weight, not to mention the wear and tear that can do to your joints. So those are kind of the two big ones that I have noticed and focused on recently.
Thank you. So thank you so much for pointing all of these out. And I'm sure that many of the people in our audience are very well aware of these too, and we will need to continue to work on these. I would really love to keep chatting with all of you, but unfortunately we're reaching kind of the end. And we've tried to cover as many questions as we could in this wonderful session, and our speakers have been so kind and also type a couple of the answers into the chat there. However, if you do have additional questions, please feel free to email them to us. We will get them connected to our wonderful speakers here and get you the answers that you would like to have. So with this, I really wanted to thank the three of you and our wonderful panel here again for your time in answering our audience questions. It was a wonderful chat that we have had. So thank you again to the three of you.